Let's now talk about the various clinical features and the various presentations of hemophilia. Hemophilia can have a lot of presentations. It can have a varied presentation ranging from a very mild disease to a very severe bleeding. It is also important to understand that genetic hemophilia, which is because of the X-linked recessive disorder, constitutes about 40 to 50% of the hemophilic patients which we see. A lot of them can also be acquired diseases because of certain liver abnormalities. For example, in someone with liver cirrhosis, the factors are not being produced, and that can also paint a picture leading similarly looking like the hemophilia picture. But for the large part, we are going to discuss the clinical features in context with the genetic disease, which is a major presentation in the young boys. In a child or in an early adulthood, the hemophilia can be very subtle in presentation. So, if we talk about the childhood, bleeding as a baby is very rare. A lot of babies who are hemophilic, they don't bleed at birth. If there is a bleeding episode, it can be a prolonged bleed from a separated umbilical cord, or for example, when the baby undergoes immunization, then we can have certain types of muscle hematomas which take longer to resolve. These can be an indication for us that in an early child that there can be certain bleeding abnormality or certain coagulation problem in a child. Moving onwards, the other presentations, which are very subtle presentations, are increased bleeding during circumcision. Along with that, there can be certain types of minor lip bleeds in a child, and gum bleeding is very specific. If the gum bleeding, if the child has undergone any dental procedure, or just because of just certain trauma to the dentine, if there is a large bleed or the bleeding takes longer to resolve, then that can be a good indicator for us that this patient or this child has certain coagulation problems or certain platelet problems that has led to these bleeding episodes. Since the gum bleeding or the epistasis, these are the features, and also in female menorrhagia, the prolonged menstrual bleeding. These features are common to both the platelet disorders and the coagulation disorders. So any patient presenting with a hemophilia can have superficial epistasis as well, or dental bleed, or the females can have increased menstrual bleeding. The other features which distinguish platelet disorders from the coagulation disorders are the joint diseases or the deep muscle injuries, the brain bleed. These type of deep tissue bleeding, they are specific for the coagulation disorders. For the platelet disorders, we will have minor epistasis. We can have superficial petechiae, and which are evident on the skin. So the superficial bleeding is generally because of a platelet disorder, and a deep bleeding is because of coagulation disorders. But there is certain overlap when it comes to epistasis or dental bleeding that can happen in both of these types of bleeding. These were certain types of subtle bleeding. The significant hemorrhages can be in various types of the symptom. These are generally in patients who have a severe hemophilia, less than 1% of the active factor. They can spontaneously bleed, or in people with moderate hemophilia who have 1 to 5% factor activation, they can undergo significant hemorrhage after minor trauma. So what happens is significant hemorrhage. What are the various types? You can have a retroperitoneal hemorrhage that can lead to severe abdominal pain, anemia because of concealed bleeding, and that can also cause shock in the patient. So that retroperitoneal hemorrhage can be because of a pancreatic disorder, just a small tear in the aorta, that can lead to retroperitoneal hemorrhage. This can also present with peritonitis as well, or back pain as well. Along with that, hematuria is a very common presentation. We can also have GI bleeding leading to melena. The intracranial bleeding can be very significant. It can lead to a lot of sequelae, like the presenting complaint might be a headache, very severe headache if it's involving the subarachnoid space. Signs of intracranial, elevated intracranial pressure will be there, like vomiting. We might have altered sensorium, and the patient can even go into coma because of this intracranial bleed. This can transform into a large clot, into a subdural hematoma or subarachnoid space injury, and that can lead to seizures as well. That can lead to brain herniation and even cause coma or death in a person. So these were the very significant sequelae of hemophilia patients, and these are the complications. These are the things which we would like to avoid in these hemophilia patients, and that's why if the patient has very less factor present or less than 1% of activated factor, then we basically consider the prophylactic therapy in these patients to avoid these bleeding, because this kind of bleeding can be lead to a lot of morbidity and mortality in these patients. Along with that, there can be certain frank bleeding like hemarthrosis, which is bleeding into the joints. This is a very characteristic sign of hemophilia patients. This hemarthrosis can start even in a young child in their when they're 5 or 6 years of age. They can lead to joint injury even after minor trauma or after fall or when they are involved in certain contact sports. And there is a cycle of hemarthrosis. Once there is a bleed, then there is inflammation that lead to swelling, then lead to some problem within the joint space, that can lead to inflammation of the synovial fluid called synovitis. The baby will have problem. The baby will move with a limb, and recurrent bleeds into a joint can lead to what we call it as a target joint. We basically term it as a target joint. If someone is bleeding repeatedly into his knee, then with every bleed there are degenerative changes into that knee or that joint space, and that in the long run can lead to osteoarthritis or various types of joint injuries. Can lead to osteophyte formation, can lead to narrowing of the joint space. So there is early onset of osteoarthritis in these patients. The joint can become completely immobilized. These patients can become immobile. So these are the feared things that we want to avoid in any patient who has a severe form of hemophilia. Along with that, there can be large hematomas and extensive ecchymosis in these patients. The hematomas can involve a lot of systems, like we saw in the brain injury. We can have hematomas in the superficial skin as well, or we can have GI hematomas. So whenever there is a hematoma, it has a predilection to bleed, and that can lead to shock and various sequelae, just as we discussed in the previous slide. So as we can see in the overall picture on the clinical features, bleeding is generally deep bleeding. It starts off as a subtle bleed in a young child. If he has around 25 to 30% activity of the factor, then he might be asymptomatic. But moving onwards, if the patient has less factor activity, if he has a severe disease, then they can lead to severe type of sequelae like a brain bleeding or bleeding into the joints. They can bleed into any orifice. They can bleed into any cavity. They can bleed into the peritoneum, the pulmonary cavity. It can present us with the help of pleural effusion as well. So these are the various varied presentations in patient with hemophilia.